role of laparoscopy for rectal cancers. I was actually initially told that I have to discuss the role of laparoscopy for colorectal surgery, so that's why I accepted this invitation. But I was not doing it primarily for rectal only. If we see the history of minimal invasive surgery, the first laparoscopic cholecystectomy was performed in 1985, and within around 7 years, this article came in 1992 that laparoscopic cholecystectomy is the new gold standard. Although the first laparoscopic colectomy, it was performed in 1991, but still it is not being widely used. Although there are many reasons cited for non-acceptance, but the most common fear in surgeons' mind is the oncological safety. So I'll be mainly discussing about the oncological safety for laparoscopy in rectal cancers. If we have to study the evidence for oncological safety, first I will be discussing the parameters to study oncological safety. I will be discussing evidence for mainly rectal cancer, and then finally what are the various guidelines available. For studying oncological safety, there are three factors. One is port site metastasis. The other is short-term concern in terms of completeness of TME, lymph node retrieval, and resection margins. And the long-term concerns in terms of recurrence and survival rates. The issue of port site metastasis is more or less settled, with lot of studies showing that there is no major difference between laparoscopic and open, and will not be discussed further. For colon cancer also, there are randomized controlled trial and enough evidence that laparoscopy is beneficial, so I'll not be discussing the colon cancer. We'll be discussing evidence available for rectal cancer. MRC Classic involved both patients with colon and rectal cancer, and they have shown that patients with rectal cancer undergoing laparoscopy, they are more likely to have complete TME. Although there was a trend toward positive margin, but that could not translate into any difference in survival. So the survival rates are similar at 3 years and 5 years. Wexner group was the first to publish this case-matched study of 64 cases, where they have shown that laparoscopy for rectal cancer is feasible and safe, and the length of hospital stay, time to tolerate a diet, all these initial parameters, they are better. And there is no short-term difference in the oncological parameters. This was followed by a Korean trial from 3 Korean centers. This was a randomized trial, 340 patients, and they included patients which were less than 9 centimeters from anal verge. This was the only first trial to include patients in the post-neoadjuvant setting, and they have shown that there is no significant difference between short-term functional and oncological results. American College of Surgeons published their phase 2 pilot study, and they have shown that the oncological outcomes, they are equivalent. And the incidence of positive resection margin was there 1 in lap and 7 in open. This was a very good study published recently in Disease of Colon and Rectum, where they have shown that in a patient series of 234 patients, the lymph node retrieval was better in laparoscopy compared to open. Although there was no significant difference in margin status, proportion of distal margin less than 1 centimeter, and completeness of TME. There are 4 meta-analyses available, out of which 2 have included rectal cancer, and they have shown that there is no significant difference in survival, recurrence, and lymph node recovery. Recently, the short-term results of this phase 3 trial, that is the Color 2 trial for rectal cancer, they were published, and they have also shown that in patients with rectal cancer treated by skilled surgeons, laparoscopic surgery resulted in similar safety, resection margins, and completeness of resection to that of open surgery. Although the final results, that is local regional recurrence, they are expected by the end of this year. In the same journal, this Lancet Oncology, there was a comment by Dr. Hedy Nielsen. They have written that we as surgeons will keep on introducing new surgical procedures or will be making technical improvement in existing surgical procedures. And it's not possible to have randomized controlled trials, or it's not feasible because of the high cost and time spent. And moreover, just to prove by randomized controlled trial, it will take a lot of time, maybe 7, 8, 10 years. So that time will be denying a good procedure to a patient. So there is a need for new models, maybe combining prospective databases or some other techniques to give the benefit to our patients. If we see the guidelines, the British were the first to include the laparoscopy, and they revised this NICE guidelines in 2009. These are the SAGES guidelines by American surgeons. They have also included technique in the surgical technique, the rectum. And they have given that laparoscopic resection for rectal cancer should follow standard oncological principles. Adequate distal margin ligation at the origin of arterial supply and mesorectal excision. And they have given a strong recommendation for that. If we see the practice parameter for the management of rectal cancer in latest published in Disease of Colon Rectal 2012, they have also included the laparoscopic colectomy in their guidelines. These are the variant of laparoscopy, that is the hand-assisted surgery. The main advantage is that the various technical challenges of laparoscopy, they are mitigated. It has been proven to decrease the operative time, especially for left and total colectomies. And there is no difference in outcomes between laparoscopic and hand-assisted surgeries. This is another variant, that is robotic surgery. There are various studies which have shown that it's equivalent to laparoscopy, but the only benefit which has been shown is probably low rate of conversion and a better lymph node retrieval. At Medanta, we are presently offering laparoscopy mainly to left colonic rectal cancers only, because we think that dissection in narrow pelvis, especially in male, is much facilitated by doing laparoscopy. Moreover, in left colon, we have to do a stapled anastomosis. And if a patient, we need to mobilize a splenic fracture in rectal cancer, if we are doing an open surgery, the incision will be from xiphi to pubis, which will be almost like a post-mortem incision. We are offering hand-assisted laparoscopic surgery to patients who present lately, like advanced cases, patient presenting with obstruction, patients of morbid obesity. We had operated one patient with the weight of 130 kg, and patients who are requiring adjacent organ resections or who has undergone previous surgery, because time wasted in pure laparoscopy can be avoided. We just had a conversion to 4 cases because of previous adhesions. So these are the views which you can see that after giving the first incision, the CO2 that dissects the retroperitoneal plane. And this is the view of the pelvis in laparoscopy. See, these kind of views, I don't think this is feasible in open procedure. This is the anterior view showing the seminal vesicle, and this is all the whole pelvic dissection has been done, and you can see the pelvic floor muscles. We have performed 181 left colonic resections, majority of them being for malignancy, and around 73% they were for hand assisted. These are pure laparoscopy, and 1 or 2 we have tried robotically also. These are just the short-term results because we have not analyzed our data as yet. 72% patient had neoadjuvant therapy, the mean time blood loss, and they were equivalent to all the other studies. So to conclude, there is level 1 evidence for laparoscopy in colonic cancer, but there is enough evidence for use in rectal cancer. The main thing in laparoscopy is the surgeon should be experienced, and there should be no compromise on oncological safety, whatever we are doing, maybe laparoscopically or open. Thank you.